Okay, welcome back. We are going to be performing a Deuk plasma rhizotomy on the sacroiliac joint on the right side for this patient. The first nerve we're going to destroy is the L5 dorsal ramus, I think it is. Let's have the coker. Shot, and we'll show you. Show us the target there, Jordan. Shot. Pretty much right where the tip is. Shot, and he's got a lot of scar tissue. I'm feeling it right now. A lot. That's a lot of scar tissue. Very unusual to have this much scar tissue here. That feels solid. Give me a second. Shot. We're going to take a look. It's a little lower than I want to be. I want to be a little more north. Again, scar tissue. And scar tissue has a certain feel to it. If you're a surgeon, you've felt scar tissue, you know what it feels like. Oh yeah, there we go. Shot. We are right on the bone. I'm going to go slightly more north, but I am going to attack this area too. He's had horrible pain here. And I mean, there's a ton. It feels like, I don't even know the right word for it. Very thick. Shot? How do you describe it? I think he's had surgery back here before. Not by me, by somebody else. He has. But he had, I think he had a Bonatti procedure. Shot. And the scar tissue is, it looks like the Bonatti special. I'm just telling you the truth. We've had so many people that were treated there that have problems. Not trying to say anything bad, but just telling you the truth. Yeah. I think I know. Yeah. Definitely bad. Bad scar tissue right here. Alright, let's see if that works. Alright, now we're going to move our way down. I'm going to make another incision and go a little bit lower. He said num num for us. Shot. There we go. A little north. Oh man, scar tissue galore. That's shot. Ooh, it's thick. It makes it really hard to move the probe. Shot. There. That's the right spot. I see why. Because of all the scar tissue, makes it almost impossible to do this.
The nerve can also get stuck in the scar tissue.
That's the point, yeah. Fuck. Yeah, scar tissue galore. Shot. That is not good. Not good for him. Well, I think it's going to work, but we'll see. Huh? Shot. I mean, I'm pretty lateral to the foramen, but I'm right near the joint, and I think this is the best way. The prior surgeon that did his surgeries before us has unfortunately just done a real number back here. And we were talking earlier about how what other surgeons do can actually affect the patient's outcome in terms of adjacent segment disease, but also when it comes to operating on other parts of the spine, like the sacrum, where we're operating right now. Yeah, super thick scar tissue. Well, let's hope this works. Man, I just don't understand how he got so much scar tissue down here.
A different one, please. Thank you.
I might be able to salvage that first. Hmm?
It's good. You want another one open, sir?
No,
No?
let's try this first. Yeah, that's better. Let's see if this works. See, with a thicker scar tissue, that may be the problem, is we do need concentrated charge. Why don't you open another one? It's eventually getting it, but I'd rather open another one, prep it. I mean, I can feel the layers of scar tissue.
Well, it definitely has a distinct feel.
Well, I'm on the bone. I'm on the surface, where I need to be. But the problem with scar tissue is it just sucks out the energy,
Next one is ready.
and it makes the charge less effective. You got it?
I got it.
Let's switch it out. And you use another wand. What happened to the ones that you were using before? Shot?
I still have back there. It's just that I didn't use it there. I can use it for the next case if you want.
Shot? So for those of you who don't know what we're doing, the joint to our right. Jordan, show us the joint. That joint right there is called the sacroiliac joint. And that joint is where his pain's coming from. Arthritis in that joint. So what we're doing is a denervation procedure where we're going in and basically killing the pain nerves to that joint. What I'm saying though is that unfortunately he's got a lot of scar tissue. And that's making it very difficult to treat because the scar tissue covers the nerves that we're trying to destroy, the pain nerves, and it basically keeps them from being burned, which is what we're trying to do. All right.
You gonna end that video or
No, we're going to keep going. Shot. Num num. Now we're moving on to the piriformis. This patient has a torn butt muscle and pressure.
you like me to rotate the mic?
Absolutely, go ahead. Shot. Is that where I am?
Yes, sir.
All right, go ahead.
Yeah, fine, but
Let me know when you're done. Shot. All right, you can see that already the posterior facet has rotated laterally very nicely. have another one available in case we need it.
Tip, please. Stand by. Thank you.
Hold on. Shot. All right. Shot. We got to navigate right there. See where the tip is, folks? That's exactly where we want to be. Shot. I want to dock my tip right on that bone. And there it is. Hold on a second. And shot. I feel it. It's perfect. Got to come a little bit more medial. And this is where your piriformis muscle is. It attaches right here. Shot. Uh-huh. Man, he's got a very anterior greater trochanter. Shot. We're in great position for the release. I'm very happy with our position. And hopefully this does the trick. So the problem with piriformis syndrome, it's very common. It causes a pain in the butt, literally a pain in the butt. And shot. It's very hard to cure without surgery. Almost impossible. You need to do extensive therapy, and you have to basically stop using your body, because any kind of movement of the hip or leg will shot basically re-tear, re-injure the muscle. You hear it? You guys should hear it. It sounds like a guitar string.
Yes, we do. Yeah,
You can hear it?
a little bit. It's very, it's
That's
faint, but we can hear it.
amazing. Yeah. Shot. Yeah, so I'm basically sweeping from low to high. And the good news is there's nothing that you can really injure over here. Now, if we go towards the sacrum, you can injure the sciatic nerve. We don't want to do that.
Almost completely off the screen.
Huh? What?
The sciatic nerve
Right, yeah, we're nowhere near.
off the screen. Have you seen the videos of them doing this arthroscopically or open?
No.
Arthroscopically, they fill that soft tissue up with water, and all the fat swells up, and it makes it nearly impossible to navigate. Takes them forever to do it.
Yeah, we tried it arthroscopically.
Yeah, that didn't work.
And open is very painful. If we did it open, the cut would be like this on his butt. And he would lose his gluteus maximus. But look at the incision we did. 4 millimeters.
And you'd have to split the fibers of the muscle and get all that scarring. Now you just pierce it.
Yeah. And he's already got way too much scar tissue from the prior surgery. So thanks, everybody. Good job. Let's hope this works for him. We're going to keep our fingers crossed. But I've done everything I can.